I don't think he needs a lot of introduction. He has spoken with the group before. He's actually at Pacific University teaching PT and chronic pain today. So he is here, and Margaret will join us soon, Margaret McReynolds, for DNM to really go more advanced than before. So, Bill, kick it off.
Okay, hi. I'm so happy to be here and to share this with you. You know, this is a technique that I use almost every day. Margaret too. It's not something it's not a miracle cure for everything that happens, but it's one technique for working with people with musculoskeletal pain, and I'm just happy to talk about it. So let's see, let's go through some of these slides. If you have any questions at any point, then feel free to interrupt me or to put something in the chat. Connie, can you just keep an eye on the chat for me?
Yes, I can.
Okay, thanks so much. And let's just start at the beginning and see where we get. I know some of you were here last year and some of you weren't. Let's see where we go. Uh-oh. Advancing a slide. There we go. So what I'm going to try to do, Margaret and I, is provide an understanding of the principles of dermal modulation, talk a little bit about the neurological basis, and then talk about some techniques that you can use. We're trying to make this as practical as possible so that you can use these techniques tomorrow or the next time you're in the clinic. Dermal neuromodulation is a manual therapy for peripheral nerves, especially cutaneous nerves. Cutaneous nerves live in this are in the skin. The skin is full of them, and when they become sensitive, then people will feel pain that can be relieved to a good extent. So let's see. There's out of all the sensory nerves, some of them are sensitive to mechanical forces like pressure or stretch. Some of them are sensitive to light, some to temperature, and some to chemicals. And if they get the right stimulation, then they'll transmit that into an action potential, which is just a nerve signal, which then travels up the sensory nerves to the dorsal horn of the spinal cord and ultimately produces some kind of an experience in the brain. Many incoming signals from this sensory nervous system are filtered out and the patient never experiences them, but many others get through. Now, there's different types of nerve fibers. There's C fibers, which are slow, and A fibers, which are faster. There's A beta fibers and A delta fibers. Delta fibers aren't on the slide, but they're still there. Delta fibers tend to carry nociceptive signals, signals that show a large change or a fast change in the tissues. A beta fibers tend to be non-nociceptive, which that just transmit sensations like touch, things like that. And so we're going to talk about both of them. Nociceptive capable neurons, mostly the A deltas, have a high threshold and are modality specific. So what is hello, Margaret.
Finally, I was WebEx was just forever slow.
She's here. We're on slide number 3 or 4. I'll take this one and then you get up and running and take over anytime. How's that sound?
That sounds good.
Okay, so still talking about the nervous system. Nociception are signals that encode irritating or noxious information and carry it to the brain. Like I said before, the brain doesn't always pay attention to nociception, so you can have nociception without pain. You can also have pain without nociception. They're two related but distinct things. And it really depends on the experience that a person has, depends on the full context of what's going on in that moment. It's not just nociception from the tissues or certain signals from certain nerves. It's a full picture that determines their experience. You want to take one, Miss McReynolds?
Okay, so the receptors that we're most concerned with are the Ruffini receptors found in the superficial dermis, where they record low frequency and vibrational pressure. They are slow in adapting to pressure that result from stretch of the skin. They then bypass the part of the brain that processes nociception. So by putting a slow, sustained stretch into the skin, we're providing the brain light, fluffy, soft information about whatever body part we're working on. So this is just a picture of how the raphe corpuscles and nerve come to the surface.
Yeah, there they are. Oops.
So again, this is just a picture of the pathway through the nervous system of how that information goes up through the dorsal column.
Can you see me moving my mouse around on the screen?
Yes, I can.
Okay,
Yes,
well,
we
so here,
can.
okay, I'm glad I know that. Here you can see the raphe receptors will take this input and go through here, and then they'll send a strong signal to the brain, which will inhibit incoming nociception that would come through here. And so the person will experience less pain.
So this is just a picture of the homunculus. Remember, our brain is mapped, our whole body is mapped out on our brain. We have a sensory map of how we perceive ourselves and a motor map of how we move. And when you have chronic pain, what happens is this body map gets smudged. So you lose distinct good communication with self, which can then lead to poor movement patterns that perpetuate pain states. The nice thing is you can tighten this map up through sensory information and directed exercise. As you notice, the face of the hands take up the largest amount of real estate, and that's why we covered it in the first webinar on dermal neuromodulation, because it's a great way to access the brain and calm down the central state. Because if the brain is calm, you feel good, you move well. Do you want to add anything to that, Bill?
No, I think, yeah, I think that's good for this slide. We're trying to change the total context. So to reduce their pain, we're modulating their pain through touching their skin and moving the nerves and the skin. And that's where the modulation, that's how we modulate. All right, next slide.
Okay.
Oh, we're getting into techniques now.
All right, so this webinar we chose to look at the shoulder and the spine and the abdominal wall. So this first picture is T2, and so when this becomes restricted, you have restrictions in shoulder range of motion or persistent pain down the back of the arm or across the chest. So one of the ways we look at this is, well, if they're saying, oh, I get pain when I move my arm over my head and it goes down the back of my arm, we say, well, raise your arm up, and we see how high can they raise their arm. And then we retreat this, and then we come back and see has that range improved, that pain-free range. So we have a nice video of this.
Here it comes. Can you hear the sound?
No.
Yeah. Huh. I can't hear the sound either. So I'll narrate what I was talking about. My hand is right on the shoulder blade, sort of the scapular area, and I'm just gliding the skin down toward the bed. And my other hand is grasping the skin at the elbow and putting a twist lift with it. So basically drawing it apart. And I'm just listening to Bill's tissue, because as he starts releasing, the skin and tone starts to soften. And you'll get a retrofeed feedback. As Bill relaxes, that actually makes me calmer. So between the two of us, it just helps the whole system relax. And then after it's totally released, you're going to just slowly disengage and take your hands off. So as you can see, these techniques take a while. This is not fast. This is got to be willing to just kind of hang in the tissue as it softens.
So you can't hear the sound on the videos?
Now, I can't hear it, Bill.
No, we can't.
All right, well, so Margaret will talk. I don't know how to fix that without taking up a bunch of time. I can hear it perfectly. Let's just go to the next technique. There we go.
All right, so this is for the axillary nerve, C5, C6. The point that you're going to be palpating for tenderness or irritability is in the axilla at the lower end of it. And people will complain of posterior arm pain and anterior. So the anterior part of the shoulder arm and then the posterior part.
Ready?
Ready. So my thumb is just monitoring that tender point in the axilla. And it'll have a firmness to it when it's tender. And now I'm just positioning his arm and I'm kind of playing with the twist of the skin. And what I'm wanting to feel when I twist the skin is which direction does his body like it best. Right? Because remember, these fibers come in from all different directions, and some people have a directional preference. So what I'm doing here is the stretch of the skin for him is inward. So I'm twisting the skin internal rotation. And I'm just, now that thumb's just listening for softening. And the other thing you can see is Bill's breath changed. He's breathing deeper. So you want to sort of pay attention to the body signals because the body's going to tell you if you're getting that system to let go and relax. And again, you come out of it slowly and disengage slowly.
When I first started learning this, I thought it was maybe metaphorical or kind of funny that you could feel people's tissues soften under your finger, but it didn't take very long before I really could feel it. And it's not, there's nothing metaphysical about it. They're just relaxing their muscles and softening up. There's tension releasing under the skin. Do you agree with that?
Yeah, I agree.
Yeah.
And like I said, when your hands stay soft, you don't have any tension in them, you can feel a lot more. And really, we're designed for auto feedback. And so if his systems are starting to relax, I can feel my system starting to relax.
So there's two questions. How long in each position? Sorry, I talked too much today.
That's a good question. 2
How
minutes is
patient
what the
feels.
textbook says. Sometimes it'll soften up sooner than that. You don't have to wait every 2 minutes every time. Sometimes it takes a little longer.
Yeah, it's really paying attention to the tissue. So some techniques, you know, maybe it's just a minute. Other techniques, it might be 3 minutes.
I don't know if we talked about it this year, but so the first finger, you're looking for a tender spot. I'm going to move like here under her left thumb. She's looking for a spot that's tender. She's going to say, "Is this tender?" And I would say, "Yeah." If it wasn't tender, she'd find another spot that was. And then as she changes the position of my arm and puts some tension, then that tenderness should reduce by 75%. I think that the reason they say 75% is because if it had to reproduce 100%, it's too much pressure on people. But you want it to produce a significant amount, otherwise maybe they're just being polite. So the book says get it to reduce by 75% and then hold it there for 2 minutes.
Okay, and then which patient scenario would you decide to use DNM in addition to the usual chronic pain management program?
Well, like we said, I use it almost all my chronic pain patients. So right there, because it's non-threatening, it is a great way to calm down the nervous system in relationship to the body part. And then that way the person's going to be more receptive oftentimes to movement, which before might have been challenging. So again, in this case, the pain is in the upper arm, so we would be looking again at that shoulder range of motion and how much can they move it before it starts to bother them. And so we would test that, and then we would retest it when I'm done and say, maybe go look, oh, my hand's way up here now, and I could only get it to here before, so that they can see and feel the difference.
Sometimes it's really very dramatic, but so I wouldn't necessarily expect, like if someone has a frozen shoulder, I wouldn't expect this to completely regain all their motion in their shoulder, although it might help them for pain at rest within the range that they have. But you'll see lots of patients where they can move, but it just hurts. And so then this kind of thing comes in really handy. And then the neck and head stuff that we showed last year will help a lot with like headaches and pain at rest, or just pain with just lifting, holding your head up, keeping your eyes open, stuff like that. Good question. What do you think? Should we keep going?
Yeah, let's do the next one.
All right, this is another. Is that the same one?
Looks like it's the same one, Bill. There we go.
There we go.
So this is for the supraclavicular nerves, T3, intercostal brachial, and T2. So this is when mostly people complain of anterior shoulder pain. So what I'm doing here is I'm geckoing my fingers to his anterior skin of his chest, and I'm doing a drag backward.
Yeah, she's pulling this way.
Yeah. So all I want to, and I want my hands are monitoring the tension in the anterior part of his shoulder. You can always ask the person for feedback. How does that feel? And, you know, it should never feel ouch. That's the other thing. It should never increase nociceptive inflammation. If it does, lighten up, change the direction.
So
now,
that's what you,
yeah.
That's what she just did. She just changed her direction. Here, keep talking. I'm listening.
So now I'm doing what I call a bubble technique. This is where we basically bubble the skin up. So the top looks like a little bit of a bubble. And he really liked that one better than the first one. So sometimes you want to play a little bit to see which gives you a more powerful response in the body.
Do the patients have to concentrate during the DNM, such as breathing control?
Nope.
Good question.
It's a good question.
No.
But I don't have them worry about breath. I'm just having them hang out. But I do watch their breathing, and I know when I'm getting physiological relaxation, the breath changes.
Yes. We have a bias in our education that if somebody's in pain, that it must be a muscle or a joint or something like that. But the skin is the largest organ in the body, and it's full of nerve endings that are capable of provoking a pain. And you can relieve a lot of pain by working through the skin.
Yeah,
right?
It makes up some 19 square feet plus or minus, depending on how tall you are.
It's a huge organ. Ready for the next one? So just in case, if you go back a slide, there's two, whoops. It'll show techniques before the slide,
And then on the next video, you'll see how she does it. So you can go back for yourself and look at the slide and see what she was doing, and then go ahead and watch her do it. See, there's the slide. There's her doing it. Ready?
Mm-hmm. So this is suprascapular nerve and posterior supraclavicular nerve, C3. And the pain is, you're looking for a tender spot across the top of the shoulder. And then when you find it, that's your monitoring point. And then I'm going to play with the twist of the skin. Which way does Bill like this twist? And he likes it internal. And Lizzie's helping. And then again, you're waiting for that top pan that's monitoring for the tissue to soften. The other thing that dermal neuromodulation does besides regulating the central state in the brain, it's actually improving the local circulation and perfusion of the tissue, because along with the raphe receptors come blood vessels and lymphatics. So you are having a local effect on the tissue as well as a central effect in the brain.
This is a good one.
And what I'm describing there is just what I'm feeling underneath my hand as I treat. I'm talking about how the tissue is changing and softening.
Does this technique relate to dermatome or myotome?
Ooh, good question.
Well, to a certain degree, dermatome. Myotome would be different, only because they're going to travel along these patterns like C5, C6, that's a dermatome. And a lot of the pain will be somewhat dermatomal, but not always.
Yeah, just follow what you find. The more you know the neuroanatomy, then you sort of gives you clues about places to check, but then just see what you find. Should we do another one?
Yeah.
Ready?
Mhm.
This is the same one again. There we go.
Here we go. Yeah.
So
So
new
looking on the suprascapular nerve, the inferior branch, and axillary nerve. So the tender point is going to be on the upper, kind of right where the humerus and the scapula come together there on the side. And you would probably kind of palpate around there to kind of find, oh, there it is. And like I said, there'll be a bit of firmness or hardness to the point as well as being tender to palpation.
All right, you ready for the slides for the video?
Yeah. And again, see how I'm kind of playing with the skin twist? Which way did Bill like it? Which way made that point start to soften? You're just hanging with it. You're not in a hurry. You're chatting about what you're going to have for lunch, the weather.
This is a really common place for people to have pain that just keeps coming back and doesn't go away. And sometimes it's hard to get that last bit of elevation in the shoulder.
And yeah, if you can't get that elevation shoulder, what you're going to do is drop the shoulder down a little bit and out. And then at that point, I might then put a stretch at the monitoring point away as well as the twisting motion to really get more through that area. And again, test, retest, what does the shoulder range look like? What does it feel like when they move it? You know, does it feel freer to move? Is it less painful to move?
Yeah.
So another question, this isn't really about sets, is it? Um, how many sets do we need to do for this technique? Or is it you do it for the 2 minutes and then you test, retest? Can you describe that?
Well, generally, it's not about doing numbers of sets. You're waiting for that tissue to soften, and then you can do test, retest. And then if it's better but not 100%, I might take it into the stretch in a different direction of the skin and see if, okay, what kind of response am I getting? Is this a response that the tissue likes, doesn't like? I might come and do a bubble technique over that tender point that we've been monitoring, just a different technique. Because remember, these nerve fibers come in at all different directions. So you may have gotten a lot of the nerve fibers released, but we still got a couple that are coming in from a different direction, don't want to stretch.
Sometimes it's more of an art than a science. You did your round for a couple of minutes and they're sort of better, but they're not all the way better. And you have to decide whether or not you want to do it again or move on to something else. You can check in with your patient and just sort of use your instinct and just figure it out. Do your best. Sometimes it takes a couple of rounds, but oftentimes it doesn't. Right? That's what I think.
And so I'm generally not doing a body part more than 1 or 2 sessions because they're getting better and we're moving on to other things. The only caveat to that would be doing the face and ears, because if somebody comes in a very anxious state and stress is really, really high, I want to calm down that nervous system. And because doing the face is innervated by cranial nerve 5, which talks to lots of parts of your brain, including your limbic system, I want to get that state calm. So then whatever else we do is going to be more effective. So that would be a caveat on repeating something. But I'm repeating it because I want to physiologically calm the central state down. I'm not treating the face.
Some of this sounds complicated when you talk about it, but when you just get started trying it, then you'll see what's working, what's not, and you're talking with your patient, the person in front of you, and it starts to just seem pretty natural. And again, it's not your whole entire treatment for everything. It's just a piece of like a larger approach. Next slide.
Yeah.
Bing. What? There we go. Oh, these are good.
Okay, so now we're going to be looking at the dorsal cutaneous nerves of the thoracic spine. Now, this is really good for people whose sympathetic nervous system is really activated because the sympathetic is kind of T1 to L2. So you can get a lot of calming effect in this.
There we go.
There we go. So I'm starting on the lower thoracics here. So my hand is monitoring his paraspinal tone at about L1 to about T10 or so.
Around here, yeah.
And so, and then when the stretch, my arm is going, the stretch of the skin is down with rotation in on him. But it could be down and rotation out. It's what the preference he has. And I stayed with intro rotation because I got a really good relaxation response. And so now I'm just monitoring, waiting for that softening of the tissue. And sometimes because of the autonomic nervous system and you start relaxing sympathetic tone, sometimes like their stomach will gurgle or make noises, and that's just because the relaxation is going on. So you can listen for auditory sounds as well. They'll tell you, oh, we're moving in the right direction for calming down the nervous system. You come out easy. Now my hand's I'm just moving up the thoracic spine here. This is kind of reaching for those mid-thoracics. So arm's going to go across the upper chest. And again, the pressure is down, the stretch is down his arm. This one doesn't really have much of a twist to it. This one, I've got a really good relaxation response with just the stretch of the skin down. And again, you might get some gurgling sounds. And there we got a breath response out of Bill.
It feels good.
Yes, Bill was almost asleep by the time we were done with these videos. Again, coming out slow. Now we're going for upper thoracics. So my monitoring hands from T1 down to about T4, 5. And the stretch again is going to be upward on his arm or downward on his arm. And maybe a little twist in the skin depending on how that person's feeling.
And these precise positions aren't set in stone. If you try this one and you're not getting a softening, if the tenderness isn't resolving, then just try a slightly different direction. Twist the arm, move it down a little bit or up a little bit. Like
Yeah.
you sort of try to find it, you'll find it.
And this particular one, if they have shoulder problems, may be uncomfortable in this position. So I would just lower the shoulder, lower the arm down. So I'm not, crunching up the shoulder, and then still, sustain that stretch. But then I might put stretch with my other hand at the same time to get the softening. So, because we don't want to do anything either by position or technique that creates an ouch.
Yeah, not with these techniques.
Yeah.
Next slide.
Yeah,
Next slide. Ooh.
So again, some different ways of looking at the dorsocutaneous nerves and technique.
Ready for the next one?
Mm-hmm.
Oh, Tun's got a question. Can you see Tun's question?
No,
Is the arm stretched by passive or does it need to be active movement?
you're not stretching the arm, you're stretching the skin.
Yeah.
And it's passive. As far as you're doing an active skin stretch on the skin, but the patient is passive.
Does that answer your question, Tun? That seems clear. All right, here it goes. He said thanks.
So this is a case of where I'm doing a bidirectional skin stretch. So one hand is going down, the other one's stretching up. And again, I'm waiting just for the tissue to soften underneath my hands. You can do this in the middle, you can do it up, you can do it down. Again, if you're not getting the response you want, play with it.
This one felt good.
Yeah, you like this one. So now I'm just putting a skin drag up and forward.
Yeah, like this way.
And Bill really liked it. He was just going, ooh.
We use this technique for a patient with allodynia. Another good question. No, I wouldn't use this if, yeah.
I would, if I were to treat somebody with allodynia with neuromodulation, I would be treating the head to calm down the central state more than that body part. I would probably treat the other side. So if the allodynia, say, was the right hand, I would treat the left hand only, and you get a crossover the cord that helps calm down that hand without having to directly treat it. And I'm in a light sensitive room. Let's turn on.
Yeah. That's a good question, though. There's a lot of ways to work with people with allodynia, but neuromodulation is not one of them. Not over the allodynic part.
Yeah.
Crossover technique is good, though. Yeah, yeah. Yep, she's still on it.
Margaret, did you do this on Dr. Wanapa when you were in Thailand?
No. I did
She says
neurological.
yes. She says yes.
No, I gave her the tennis balls for the self CD4.
Oh, you did for her shoulder. You did one.
For her shoulder, I gave her I did the neurogliding.
Oh, okay.
I always think this technique is kind of like neural gliding for nerves that don't cross that many joints. They're just for smaller nerves. I don't know.
Yeah.
Kind of made that
Yeah,
up, but it makes sense to me.
No, it makes sense to me, Bill. Yeah, because you're mobilizing those little tiny receptor nerves. So it is a form of neuromobilization when you think about it.
Almost to the end of this one. There, see, she comes out so slow. Okay. Next, ready for the next one? Ready for the next slide, Ms. McReynolds?
I am ready if you're ready, Bill.
Oh, yeah, here we go.
Oh, the abdomen. Yeah. And Bill really liked this too. So I use this for people who have a lot of scar tissue in the abdomen. They've had multiple surgeries, C-sections that remain painful in the scar area. I see a lot of patients with Crohn's who have had multiple abdominal surgeries, and they have a lot of abdominal wall pain that's not necessarily related to the viscera. So on this one, I'm drawing the skin toward the chest. And again, we're listening to that softening of the wall. And if it's done right, a lot of times people will feel that stretch in the skin all the way down into their groin and upper thigh. So I wasn't getting exactly what I liked with that. So I moved a little bit lower on Bill's belly. and did the stretch. And boy, he really liked it there. It was just like instantaneously like, oh, you found the spot.
Yeah. This is a really good example of a skin lock. So she just rests her hands on my skin and then kind of sticks and then drags the skin. You see her fingers are relaxed, her arms are relaxed. She shifts her weight back.
Yeah. There's no tension. When you
Yeah.
have no tension in your hands, you can feel so much more. If you're tense in your hands, unfortunately, then you have A beta fibers firing instead of C fibers are tactile. All right. So I'm listening with my C fibers because my hands are relaxed.
And it doesn't take a lot of force. She's not like lengthening my tissues like the way they teach in PT school. She's just putting a stretch on and then my body's responding. Doesn't take a lot of power. Oh, there was a good question there, but Connie, I lost it. Could you pick that up?
So it's how different pressures between dermal neuromodulation and fascial release technique. Do those techniques quite not the same or not? They're not the same. When you're doing myofascial, your hands are sinking deeper into the tissue, moving through the subcutaneous fat till you land on the fascia. There's a firmness to the fascia, and the pressure is greater. When I'm doing myofascial release, I'm deeper in the tissue, I'm putting more pressure in the tissue, and I'm putting a sustained pressure. If it's a cross-hand tech like this, I'm waiting for that tissue to release and my hands to move a little bit. And I hang out there and I'm waiting for it to release a little bit more like that. So they're not the same. Both techniques can be helpful in chronic pain conditions, but one is actually treating the glide of the layers of tissue. The other is treating strictly the skin and the nervous system. So two different techniques for two different reasons.
Right, but how about the pressure? So one is heavier.
Yeah, myofascial is heavier because you have to sink through all of that superficial tissue to get to the fascia. And then that stretch is a sustained stretch, usually bidirectional, and you're waiting for the tissue to elongate and your hands will move. In dermal neuromodulation, the hand, other than the initial stretch, doesn't move because it's very superficial.
All right, keep going.
So I like to do a lot of work around the navel because we have a lot of neurology around the navel. Remember, that was our connection to our mamas when we were in utero. And so there's a lot of important sympathetic, parasympathetic things going on there. So I like to come in and put a twist into the skin, and I'll play with the direction out of the twist, which to feel like better. And then I'm going to do that sustained stretch of the skin in that direction. But I always check which way does it feel like it wants to go, which way am I getting a better relaxation response.
I missed.
Yes, I think we should have him autograph it, Dr. Wanapa. These videos are going viral, Bill.
Good. I'm be famous.
He's going to be a star. And this is another place I'll do the bubble technique. I'll bubble up the skin. And he really likes the bubble technique.
How are we doing for time?
We're doing well.
Yeah,
I think this is our last video.
I think so. When I took my first myofascial release class, they talked about working through layers. But they talked about in terms of working on the most superficial layer was really very much like dermoneuromodulation. You'd have a hard time telling them apart just if you watch somebody doing it. So there's some overlap. Let's see, should we, next slide?
Mhm.
Same one again. Considerations, boom.
So pre and post test, how do they move? For anything on the trunk, it'd be how well can they rotate? How well can they bend and extend? The shoulder would be how well can they move their arm, right? Before and after. A lot of this you can teach them to do for themselves. So a lot of my people with that abdominal wall pain, I will teach them how to stretch the skin on their abdomen. That's just part of their self-care at home. It tends to be very soothing. So
Do
Like
you
a
teach
classic
the
treatment for
family?
somebody with a sore shoulder, I would do some of this and then their arm is moving more easily. Now we're also happy and I might show them a couple of like classic arm exercises, just like rotator cuff strengthening or rows or just whatever it seems like they need. But I wouldn't frame it in such a way, like if they're feeling better with just a little modulation, then their muscles probably aren't torn or anything, but they still need exercise just like everyone else.
well, the exercises would help tighten up that body map.
Yes, exactly. All right, let's see. Next slide. There might not be many
Can
more.
I ask you, do you teach it to family members for their loved ones as well to do it for them?
That's a good question.
Yes, particularly a lot of my patients who are palliative patients. I teach them how to do the hands and the face. And it's actually what you'll see is when they're doing it, both the patient and the caregiver, because there is a lot of tension in caregiving, even if you're happy to do it. And there's long-term studies that show that women caretakers, even 5 years out from the death of their partner, still have elevated stress hormones. So we want them to be able to de-stress at the same time. So considerations, obviously your hands need to be clean and warm. Mine has had a hard time being warm. Kind, slow. Be intelligent with the tissue and responsive to the tissue. Well, I think what we have next is that case study, but maybe we should take more questions because our time is getting
I think
short.
I think that's a great idea. We have so many good questions.
There's no more questions, so maybe the case study would spur it, or, oh, no, Mr. Passicorn put a question in. He's so
More.
intelligent, that ton.
Can you read out his question, please?
Yeah, could you please explain more about the concept of arm position during DNM for neck shoulder pain? Do you want to go back to the,
Yeah. Let me go back. We want like one of these pictures. Oh, Margaret, I can't hear you. Did I mute?
we've lost Margaret's voice. We can't hear you.
Margaret, you're on mute.
Margaret, we can't hear you. Can't hear you.
It's not, she wasn't mute. Man, let me see if I can take this one. Can you hear me?
Yep.
Okay, so to understand the arm position when you're, Connie, do you think you could text her?
I just tried to unmute her, so yeah, I'll text her right now.
If you think about the nerves that come from the neck down to the shoulder, then you just want to move the shoulder in such a way that you put tension on or off the nerve that you're working on. So let me see if I can find you a good image here. No. Here. There. So you can see all these nerves. Any one of them can be tender. Now, Margaret is an expert and she can feel it before you even ask. And a lot of times I can feel it too. But if you're not really sure, you can just look for a tender spot and then what you think is a tender spot and then ask the patient and they'll tell you. Before very long, they'll know what you're looking for. So then you just want to move the arm in such a way to either add or subtract tension to these nerves. So you can see these are cutaneous nerves, but then there's also the spinal accessory nerve coming down through here and cervical plexus nerves that also work through here. I don't have an anterior picture, but if you look like C3 and part of the cervical plexus goes up to the top of the shoulder to the pec area. So you're gonna find your tender spot and then just try to maneuver the body position one way or another to reduce their tenderness and reduce or add tension onto the spot. You put tension on, but you're looking for a softening under your finger. Now, I can't remember all that neuroanatomy, and I don't think most people can, but you have a general idea of how it is. So then you just sort of make it up. And it doesn't take years of practice. With a little bit of practice, you'll start to find positions that work for you. And then, after you've worked with the patient, then you go look at the book again and kind of see that what you made up was the same thing that's in the book, or you figure something a little different out and you try that next time. Before you know it, you're an expert. Margaret, have we got you back? I don't know what happened. She's getting frustrated. Any more questions? Tun, that was a good question. Did I answer your question, Tun? Ask me another one. Can you apply moist heat? Absolutely. Can we ask the patient to move the arm while we stretch? I mean, yes, you can. I don't think you're going to need to practice like classic dermoneuromodulation. You don't need them to move very much. Maybe breathe. Then once they're feeling better, then I would have them move more after. But it's not a black and white rule. That's the kind of rule that's made to be broken. I think in a general way, we're trying to promote a feeling of safety and relaxation. So you don't need a lot of movement. Heat, I don't see any wrong with doing heat. If you've got the time and there's heat there, why not? I don't think it'll make it less effective. If they didn't like the heat, I wouldn't consider it be necessary whether they like it or not. But that's a good question too. I mean, yeah. Good question. Any more?
Any question from various BDMS sites? We have quite a number of people attending to this great session. How about other group? 2, 3, 4, 5, 6. Any question from you? Okay. Connie, William, Margaret. I think everyone is very clear with your live demonstration and the neuroanatomy showing. I think that it is very, very nice technique to be applied to the patient. Someone sent you the big heart. I don't know who. They sent the big heart in your WebEx. Very easy to understand. Lecture as always from you. And we wish you Merry Christmas ahead.
Merry
Thank
Christmas. And thank you,
Christmas.
Margaret and Bill. You put a lot of work in. I see Margaret's home office. If anybody comes to Portland, she can treat you at home. And thanks again. I know, Bill, you've been teaching all day, so thanks again.
My pleasure.
Merry
Thank you.
Christmas. Sawadika.
Merry
Merry
Christmas.
Christmas.
If you have any
Bye-bye.
questions, just send an email anytime.
Yes. Thank you. I'm sure they will have.
Okay, bye-bye.
Bye-bye.
Thank you very much.
Now